Hello, everyone. My name is Grace Dennis, and I'm so happy to welcome you to the 6th Annual Cannabis in Practice webinar series hosted by the Washtenaw County Health Department, the Livingston County Health Department, in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide variety of backgrounds and experts in their field. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This live webinar has been approved for 1 social work credit, 1 specific McBAT credit hour, and 1 credit hour of CME. If you are requesting any of these continuing education credits, please be sure to stay until the end of the webinar for the post-webinar evaluation survey. Please be sure to provide your name and email address to ensure that you receive certification for your attendance. This webinar is being recorded. The webinar recording and presentation slides will be available on our website at washtenaw.org/marijuana in the coming weeks. Before we get started, we ask that all questions for our speaker be asked through the Q&A function, which can be found at the bottom of your screen. I'm pleased to introduce today's speaker, Dr. Jodi Gilman. Dr. Jodi Gilman is an associate professor in psychiatry at Harvard Medical School and the director of neuroscience at the Massachusetts General Hospital Center for Addiction Medicine. She received her PhD in neuroscience from Brown University, where she participated in the Graduate Partnership Program and with the National Institute of Alcohol Abuse and Alcoholism. Dr. Gilman's research uses multimodal imaging, behavioral, and cognitive testing to understand the biological, psychological, and clinical aspects of addiction. Specifically, she studies the effects of cannabis use on addiction and other health outcomes. Her goal is to conduct research that can inform decision-making among the public, patients, and clinicians regarding evidence-based decisions to use or not use cannabis for recreational or medical purposes. If we could advance to the next slide, we have some information about the continuing education credits. None of the planners or speakers for the educational event have any relevant financial relationships with ineligible companies to disclose for this webinar series. It is now my pleasure to introduce Dr. Jodi Gilman. Thank you so much for being here. We really appreciate it.
Hello, thank you for inviting me. It's a pleasure to be here. Let me go ahead and share my screen and I'll get started. All right, can everybody see? We're good? Okay. So again, thank you so much for inviting me. This is just such a great opportunity to talk to you about such an important topic that I've really devoted my career to. So I'm going to begin this talk with my punchline. And that is that cannabis is failing to deliver the benefits that people were hoping for. Really, because of marketing and because of the media, I think that people had hoped that cannabis would be a sort of cure-all that's fun and helps people relax and helps people sleep and is helping people with medical conditions and would have none of the bad effects associated with alcohol or tobacco. But in reality, the data coming out of recent studies shows that there are well-documented harms of cannabis use and somewhat limited benefit. So let me give you an overview of this talk. In the next 40 minutes, I'm going to share with you some survey data that we've collected looking at mental health in high school and middle school children. I'm going to share some laboratory studies that we've done assessing cognition, risk-taking, and memory in young adults. And then I'll share some data from a recent clinical trial that we conducted of cannabis abstinence in teens. And finally, I'll end by talking about the medical applications of cannabis and show you results from another clinical trial that we recently completed of medical cannabis for anxiety, depression, insomnia, and pain. And then we can talk about some future directions and where I think we really need to be heading with cannabis research. But first, let's start with some background information. So I don't really need to convince anyone cannabis use is incredibly common. It's the 3rd most commonly used drug after alcohol and nicotine. Over 100 million Americans have tried cannabis, and it's rapidly growing. So Regular use is quite common, particularly among young people. In 2022, which is the last year that data is available, almost 10% of eighth graders, just think about that, eighth graders, almost 20% of 10th graders and 30% of 12th graders reporting using cannabis in the past year. So this is just an incredibly common drug. There's been greater acceptance of cannabis in the US, and this has been reflected in our politics. Public attitudes towards cannabis have rapidly shifted in recent years. Young people are the most supportive of cannabis legalization. About 36% of teens think cannabis is harmless, and 43% favor legalization, which is up from 15% in the 80s and 30% in the 90s through the early 2000s. In terms of actual policy change, as of today, I think this is correct. I have to update this about every 10 minutes. 24 states have legalized cannabis for recreational use, and 39 plus DC now allow medical use of cannabis. And I don't think I need to convince anyone here, but the approval of medical cannabis through a political process rather than through scientific research involving clinical trials is a highly unconventional approach to making decisions about medicine. And I'll argue that the rapid declines in harm perception, which is currently at its lowest point in over 40 years, often precedes increased prevalence rates. So this trend towards greater acceptance, lower barriers, has the potential to decrease barriers to access even more and increase rates of use even further. Now, why is this important? So what's happening in the background of this policy change is that cannabis products have changed dramatically. People have used cannabis for thousands and thousands of years, and that's what a lot of the pro-legalization lobbyists have been saying. This has been around for thousands of years, been used for medical indications for thousands of years. But this was always a flower-based product. This always contained low amounts of THC, the psychoactive compound in cannabis that causes the high. And what you're looking at in this slide, cannabis basically until the 2000s, is what most people voted to legalize. This is what they thought they were getting. But with commercialization comes this highly potent cannabis. So generally in the scientific literature, low potency THC is considered cannabis with under 10% THC, and high potency THC is over 10% THC. So this is the Washington market, some data from the Washington market. This THC less than 10%, you have to squint your eyes to see it, but it's this tiny little sliver down here. So this is our low potency THC. This goes to 2016. It decreases further. So this now only represents a sliver of the cannabis being sold. So what does this mean? Low THC cannabis has been virtually eliminated from the market. And now there's all kinds of new products out there. These are products that are sold. They're perfectly legal. They're difficult to detect. This one looks like a highlighter, but guess what? You can put THC oil in there. This looks like a USB drive. These can look like pens. This looks like snacks that you can have in any lunchbox. But you know what? You can bake them with THC. So these new products are being used in school. Kids can use this all day in school and nobody would know. It's not like when I was in high school and you had to go to the smoking corner. You had to sneak out and use these products. Now you could use them all day in school. People put them under their sleeves. They go like this, and nobody even knows. And these products contain very high concentrations of THC. Here's some examples of waxes, shatters, butters, hash oil capsules that can contain up to 98% THC. And again, we have this new market of edibles, which are being marketed to kids. Pop-Tarts, Fruity Loopies look very cute, but these all contain THC. The kids are getting into these products. Kids are going to the emergency room because they're getting high off these products without realizing that they have pot in them, little kids, and older kids certainly realize they have pot in them and are using these as well. Okay, why does this matter? Well, this matters because higher potency cannabis is associated with harms. I think the greatest harm and one of the most devastating consequence of high potency cannabis is this higher risk of psychosis. So psychosis is a psychiatric illness. It's in the schizophrenia spectrum disorders. And this is a chronic illness. This isn't that people get psychotic when they're high. These are people living with psychosis who have used THC. So this is a study that came out a few years ago, just that came out of Europe. And what they did was they divided the types of cannabis used by participants into two categories: low potency, which is THC below 10%, which are these bars, and high potency THC, which is THC above 10%. And then they looked at frequency, daily use, or once a week, or never. And they did this across different sites in Europe: London, Amsterdam, and Paris. And what you can see, and they looked at rates of psychosis. Non-users are these blue bars. So rates of psychosis are about 1% among the public, rates of schizophrenia. But then for the people who use THC, particularly high potency daily use of THC, they had between 5 times the odds and 9 times the odds of developing schizophrenia. So just think about that for a minute. So most people who use cannabis will not develop schizophrenia. This is still a highly unlikely condition, but some people will. And the people who will are more likely to have used daily cannabis with high potency products. Cannabis is particularly harmful to the adolescent brain. We know that adolescence is a uniquely vulnerable time where effects of cannabis are magnified. Cannabis is more addictive in kids. Cognitive effects are worse in kids than in adults who use cannabis. And the reason is because the brain is still developing in this point in the human lifespan. During adolescence, the brain undergoes significant structural and functional changes. And one of the most notable changes is in gray matter, which is what this graph is showing. Changes in gray matter play a critical role in cognitive and emotional maturation. And what you can see is that throughout adolescence, gray matter decreases in a process of neural refinement that makes the brain's processing more efficient. And this strengthens important neural connections, eliminates less useful ones. And the changes in gray matter during adolescence are linked to improvements in cognitive abilities, such as working memory, processing speed, executive function. And as the brain restructures, adolescents experience changes in emotional regulation, social cognition. And what is important for this talk is that cannabis is thought to interfere with these processes. There's a broad distribution of THC binding sites in the brain. You can see these little dots are the THC binding sites throughout various regions of the brain: the basal ganglia that's involved in motor control and planning, your amygdala that's responsible for anxiety, emotion, and fear, your neocortex responsible for higher cognitive functions, hippocampus, which is important in memory and learning, and your cerebellum, which is important for motor control and coordination. So THC affects all these areas of the brain, and it has a broad distribution, which is why there's clear functional impairment associated with cannabis use. And I'm going to talk about that now through some of the studies that we've conducted on the effects of cannabis on mental health, social cognition, and memory. So first, let me show you some survey data. So my colleague Randy Schuster recently conducted a school-wide survey study in Massachusetts. She went into 60 middle and high school schools across Massachusetts, surveyed over 20,000 students during the past school year, ages 14 to 19, assessed use of all substances, cannabis, alcohol, and nicotine, and looked at mental health outcomes: suicidal thoughts and behaviors, depression and anxiety, psychotic experience, and ADHD symptoms. So let's start with alcohol. What we see with alcohol is a dose-dependent increase between the amount of use from never, ever, monthly, weekly, near daily, and prevalence of suicidal thoughts, also prevalence of depression and anxiety. So the more you use, the worse your symptoms are. This is nicotine, and you see the same pattern. People who use more nicotine have more suicidal thoughts, worse depression and anxiety. And here's cannabis. So interestingly, cannabis is no different. And let's take a moment to process what this means. Compared to kids who do not use drugs, suicidal thoughts increase by 5-fold in the kids who use substances daily. It doesn't matter what the substance is. For people working in schools, what this means is that these kids who are using cannabis are also struggling with other mental health issues. Historically, kids caught using drugs in school have been alienated or disciplined or even expelled from school, which further increases alienation. But what this data suggests is that these kids need more support. These kids who are using drugs aren't doing well. They're struggling with other things. We see the same trend, more psychotic experiences and more ADHD symptoms in kids who use any substance daily. And interestingly, we compared our Massachusetts sample to a national sample in the Youth Risk Behavior Survey, and we find the same thing. It's not that something is going on in the Massachusetts, cannabis industry. This is throughout the country. When you look at kids who are using substances versus kids who aren't, they have worse mental health. Now, why is this important? These data are interesting because compared to other widely used legal and illicit drugs, perceptions of harm of cannabis are quite low and perceptions of safety are quite high. So this is a bar, and this is perception of safety of marijuana. So you can see LSD, cocaine, heroin, cigarettes, alcohol, perceptions of safety have remained pretty flat from the 90s till today, whereas perceptions of safety of cannabis have gone way up. And this graph shows that since 2006, people who say that using cannabis poses minimal or no risk has doubled, where other substances have stayed constant. And here's the other side. I showed you perceptions of safety. This is perceptions of risk. And you see risk of using cannabis regularly, occasionally, or once or twice. And in 12th graders, there have been a rapid decrease in perceived harms of cannabis. But what we can see from the survey data is the neuropsychiatric profile of kids who use cannabis looks no different than those who use alcohol or nicotine. But when it comes to cannabis, people have this low perception of harm, which is different than alcohol or cigarettes. Why is that? We could talk about that maybe more in the Q&A. I think there's a lot of reasons why it's seen as different than, alcohol or tobacco, but I think a lot of it has to do with the media, and a lot of it has to do with public health messaging. Okay, so what are our take-home points? Cannabis use is common. Cannabis use is associated with worse mental health in kids. The potency of cannabis is up, so it's highly potent, and its potency is associated with psychosis, and risk perception is down, which is associated with increased use among everyone, but particularly adolescents. What about risk-taking behavior? So as part of this study, we also looked at risk-taking in these adolescents. And remember that part of the adolescent brain that's still developing, the prefrontal cortex, is responsible for functions like risk-taking and decision-making and impulse control. And cannabis use during this critical period can alter the maturational process of these functions. So risk-taking is a domain that we care very much about, and I want to show you some data that we found. We had our participants in the study complete a risk-taking scale, which assessed risk in various domains. It looked at social risk. So it said, how likely are you to disagree with a parent, wear unconventional clothing? We look at recreational risk, bungee jumping, downhill skiing, financial risk, like investing and gambling, health and safety risk, unprotected sex, riding a bike without a helmet, and ethical risk, like shoplifting, cheating on an exam, and so forth. And we looked at people's marijuana use and their likelihood of engaging in these risks. So what we found, these were our cannabis users and these were our controls. And what we found was that the kids who used cannabis scored higher on social, health, and ethical risk-taking outcomes. Thinking back to our earlier data on mental health outcomes, this graph indicates that kids who use cannabis might not only have more mental health symptoms like depression, but also might be more impulsive and more likely to engage in health compromising risk-taking behaviors that are likely to have functional impact. They may be more likely to have unprotected sex or challenge authority. And for those working in schools, these are things that you might want to talk to these kids about. These are domains that can be explored in universal prevention programs or targeted interventions. These risk behaviors, unfortunately, extend to driving. We know that cannabis affects the parts of the brain underlying motor control, planning, attention, And epidemiological evidence have shown that cannabis use can double the risk of a fatal motor vehicle accident. But what do we find? Survey in 2018 shows that young adults in particular are very willing to drive under the influence of cannabis. What this shows is that ages 21 to 25, over 10% of kids are likely to use cannabis. Not saying that they will, they actually reported using cannabis while driving, compared to very low rates of other drug use. So what I think this means is that we've done a good job conveying the danger of driving while impaired from alcohol, and we have all sorts of programs that provide kids with safe ride homes. We have all these drunk driving messages out there, but there are a few programs like that for cannabis, and it seems like we need to improve our public health messaging around cannabis and driving. So far, I've talked about the functioning of kids in non-academic domains with peers or with risk-taking. But now I'd like to show you some studies we've done looking at how kids learn and how cannabis affects learning and memory. So the most common and persistent cognitive deficit associated with cannabis is poor memory, which can clearly have important functional outcomes on school performance. In the next study I'll present, we brought college students into the lab who either did not use cannabis, used cannabis before the age of 16, or started using cannabis after the age of 16. And we had them do a memory test. Memory test is pretty easy. We read aloud a list of 16 words. The participant had to read it back to us. We read it aloud again. They repeated it back again. We did this 5 times. Each time they're supposed to improve their performance. And then there was a 20-minute delay, and we asked them to repeat the words again. So it's a very simple list learning task. And let me just show you what this graph means. This graph shows the results of memory over multiple trials. So there's trial 1, 2, 3, 4, and 5, and the delay. And these are the number of words recalled. The total number of words is 16. That would be perfect. And what you can see is that our controls had more words than the cannabis users, so they did the best. The late onset cannabis users, again, those are the ones who started after the age of 16, did a little worse, but it wasn't so bad. And these early onset cannabis users, the ones who started before the age of 16, really showed impairment of memory that lasted throughout all of the trials. Now, what's interesting is in the early onset group, the starting point in trial 1 and their progression are below those of the other 2 groups. And this suggests that early onset cannabis use might affect the ability to learn new information. So it's not necessarily a memory issue as we think about it traditionally. It's not like they're forgetting. It's almost like they've never learned the words in the first place. So this was, very disturbing to us. And then we also looked at this task also looked at learning strategies. And what we found was that the list of words are presented in a disorganized way, but could be put into categories, which helps with memory. And the controls organized words into categories, whereas the kids using cannabis really showed no strategy or structure to organizing the information. And therefore, their learning was more inefficient. And thinking back to the classroom, this can indicate that these kids might need help coming up with themes or organizing new information. Now, remember from our survey that the kids using cannabis have high rates of depression symptoms. Here, we brought in participants with cannabis use, depression, neither or both, and we had them do the memory task. And what you can see is this really interesting dose-dependent response. So this is total number of words that controls recalled, cannabis users, people with depression, and then people with both cannabis use and depression. And what you can see is those kids with cannabis use and depression did far worse than the other groups. And then when we looked at the delay period where we asked people to recall the words after 20 minutes, we see a really stark difference between controls and kids with depression and cannabis use. So this means that there's really, a lot of people say they use cannabis for depression, but there are really strong cognitive impacts that are quite negative for kids with depression using cannabis. So what I've shown you so far is this connection between more cannabis use and worse outcomes, worse mental health, worse cognition, greater risk taking. But our question is really why? Why is that? So the most dire explanation is causation. Cannabis is causing an alteration in normal functioning of neurotransmitters in the brain, especially in adolescents. So early use is interfering with neural development and maturation processes. Now, some people will look at this data and they'll say it's correlation. Correlation. Correlation is not causation. You're just showing a correlation between cannabis use and worse outcomes. There could be a third variable that influences both cannabis use and outcomes. The relationship might just be coincidental, right? So that's an argument. And then you have this directionality problem. Well, what comes first? Are kids with poor mental health and greater risk-taking more likely to use cannabis? So is it that the mental health and the risk-taking and the poor cognition causes kids to use cannabis, not that the cannabis is causing the outcomes? So these are hard questions. But what we can do is we can answer these questions through animal studies or clinical trials. So this is just a table, and I know it's very hard to read, and don't worry about reading all the small text. But these are animal studies where we administer drugs to rats or mice, and we looked at neural or cognitive outcomes. And what these studies have shown is that animals, particularly adolescent animals, show pronounced deficits in cognition and behavior, social behavior, neural alterations, and so forth when they were administered cannabis. And what you can see is that this is alcohol, nicotine, cannabis, cocaine, and stimulants. And what you can see is that these are all domains where the adolescent animals had worse outcomes than the adult animals when they had THC administration. So I think this is quite convincing evidence that cannabis really is causing some of these negative outcomes and not the other way around. Now, if you are not an animal researcher, which I am not, another way to study this is through randomized trials. So we can't assign kids to use cannabis or not. That would be unethical. But what we have been able to do is randomize kids to stop using cannabis, and then we can look at outcomes once they stop using cannabis. And that's what we did. Again, my colleague Randy Schuster led these trials. And what we did was we recruited 85 high school and college students aged 16 to 25 who all used cannabis. And we randomized them to either abstinence. We said, can you stop using cannabis for 1 month and provide urine samples to prove it, or a monitoring group where we say, just continue what you're doing. We don't say go use cannabis, but we don't incentivize them to stop. And we paid them. So how do you get kids to stop using cannabis? You pay them for it. And we use something called contingency management to incentivize cannabis users to stop using cannabis. We offered escalating payments over time for these negative urine drug screens. And then we could measure changes in cognition and mental health with abstinence. We looked at several outcome measures. The one that we were particularly interested in was cognition. So we looked at memory and attention. But what we often heard was that people were using cannabis to help regulate mood and sleep. So we looked at changes in mood and sleep outcomes as well. So what did we find? First result, the experiment worked. These are carboxy THC levels in urine. The group started with high levels of carboxy THC, but this is the group that was paid to stop. And by week 4, they had virtually no cannabis in their urine. And this is the group that continued to use. So about 80% of the kids were able to stop using with payments. Okay, so here are our cognitive results, which were very interesting. We expected improvement. These are the weeks. So this is week 1 to week 4. It's a 4-week study. And we expected improvements over time because they're practicing this task. So they get better and better at it. And for our attention tasks, that's exactly what we found. We have the abstinent group and the control group, and they both improved, as you would expect, over time from week to week. So we did not see an effect on attention. But look what happened in memory. So first of all, let me show you our abstinent group. So our abstinent group, the ones who stopped using from week 0 to week 1, showed a very nice improvement in their memory scores, which basically stayed constant through the rest of the trial. This is the monitoring group that were not asked to stop. And they showed virtually no improvement over the 4 weeks, no practice effects. So here is, another indication that cannabis is interfering with cognitive abilities in this domain of memory in these adolescents and young adults. They are not learning as efficiently and they're not improving over time. So this was a very striking result to us. And, this has a lot of indications for kids who are using cannabis on the weekends and thinking that they're okay during the week. And they're saying, oh, I only use cannabis on the weekends. Well, Monday morning, they're actually not okay. They're not learning as efficiently. Okay, what about mental health? Now, remember, a lot of kids state that they're using cannabis to manage their mood. So you would expect if cannabis is helping their mood, you'd see worsening if you take it away. And that's not what we see. So in this figure, the pink line is the abstinent kids and the green line is the kids who are using. And you can't really see them because they're basically on top of each other. We basically see no change over time in either group. Mood was pretty stable. Taking away cannabis did not worsen mood. It also did not worsen anxiety. A lot of people say, oh, I use cannabis to manage my anxiety. What we found was that taking cannabis away did not increase anxiety. And the thing to point out here is these kids are experiencing some withdrawal symptoms. So you would even expect maybe depression and anxiety to worsen a little bit in the ones who are not using cannabis, but we don't see that. We see no change despite withdrawal symptoms. So what that indicates to me is that cannabis isn't actually helping with mental health symptoms like people think it is. They also say, I use cannabis to help me sleep. Now, here we see an interesting pattern, and cannabis and sleep is an active area of research. And what we understand is that while some people report that cannabis helps them fall asleep more quickly, cannabis use actually disrupts sleep cycles, particularly reducing the amount of REM sleep, the stage associated with dreaming, which impacts the overall quality of sleep. Cannabis use is associated with worse sleep quality over time because users might find themselves reliant on cannabis to fall asleep. And people who use cannabis regularly and then stop using experience sleep-related withdrawal symptoms such as insomnia and vivid dreams, restlessness. And that's exactly what we see here. So what we see, these are the kids who are abstinent, and this is worse sleep. In week 1, they get a transient worsening of sleep, probably due to withdrawal. And then it goes back to their baseline. And the kids who continue using, this is actually no change. This is just some noise, but we see no change in sleep here. And we basically see that we have a small sleep-related withdrawal at week 1, but it's fully resolved by week 2. So what's happening here is that cannabis is not helping sleep, but rather people are using cannabis to avoid withdrawal-related sleep effects, which is quite different. Some take-home points from this set of studies is that cannabis does affect memory in adolescents, and those who stop using cannabis have improvements in memory and the ability to learn new information. Stopping cannabis is not associated with worsened mood, and there's a transient disruption of sleep due to withdrawal that resolves after the first week of abstinence. But overall, quitting cannabis can have a lot of benefits, physically, psychologically, and they often begin to manifest soon after stopping to use cannabis. So I really, from this set of data, there's really no downside and quite an advantage to encouraging these young adults to stop using cannabis, particularly on cognition. I'm going to spend the last 10 or so minutes of this talk talking about people specifically using cannabis for medical symptoms. And although I've talked about adolescents and young adults so far, there's very little data on the effects of cannabis for medical symptoms in the adolescent period. So here I'm going to talk about effects in adults, and I'll share the results of a clinical trial we did in adults who are using cannabis for depression, anxiety, pain, and insomnia. The important thing to point out here is that medical cannabis products from dispensaries are not FDA approved. FDA approval is how we approve medicines in this country. It assures that medications are effective and safe and properly labeled. FDA cannot evaluate medical cannabis because it's not a standardized medical formulation, and it's different everywhere, depending how it's bred, under what conditions, and so forth. Now, there is FDA-approved cannabis. There's Epidiolex for epilepsy. There's dronabinol for wasting and AIDS. This is not medical cannabis as we conceptualize it that you go buy in a dispensary. These drugs, Epidiolex, dronabinol, and so forth, you can get prescribed by a doctor from a pharmacy. So I just want to make that really clear. What I'm talking about in this trial is people getting a card and going to a dispensary and picking out some products. And again, because these products were approved by legislatures or on a ballot, they have not been through the gold standard clinical trials that other medications are subjected to. And the clinical trials that have been done are largely small and unsuccessful, unfortunately. So how do we even test this? How do you test dispensary cannabis as a medicine? So what we did is we designed a naturalistic or pragmatic RCT, randomized clinical trial, where we randomized participants to get a medical marijuana card or be in this waitlist control condition. So we said, we're going to randomize you. Some people will be able to use cannabis without delay, and others will be asked to wait to use cannabis, and we'll assess them at the same time point so we could have a comparison group. Participants could choose their own products, they could choose their own doses, and this was designed to test the system that we have in place for regulation and distribution of medical cannabis. So they were 18 to 75 years old, seeking their cannabis for pain, insomnia, depression, or anxiety. And this is really important. We excluded people with daily cannabis use or cannabis use disorder at screening because we wanted to see what would happen when people got a card. So we didn't want people who were already using cannabis heavily. And they were responsible for getting the cannabis, paying for the cost of cannabis, and so forth. So again, this is just a schematic of the study. We had the active study group and the waitlist group, and they were asked to wait for 3 months if they were in the waitlist group, and our assessments were at baseline 2 weeks, 1 month, and 3 months, and then we had some follow-up visits. We looked at cannabis use, so how much did people use, what sort of patterns emerged. We looked at cannabis use disorder, which is uncontrolled cannabis use. We had symptoms of pain, insomnia, depression, and anxiety, and we looked at cognition. Now, because we let people pick out their own products, we didn't actually know what people were using. So what we wanted to see was, what we did was a urine analysis, and we could look at these cannabinoids in their urine to see what people were using. So what did we find? So first of all, the design worked. So this is the delayed acquisition group throughout the first 12 weeks of the trial. They used at pretty low levels, whereas the people who got the card started using pretty frequently, pretty quickly. So about 3 to 4 days a week. The most striking finding of this study concerned cannabis use disorder. So cannabis use disorder is a condition characterized by excessive and problematic use of cannabis that leads to significant impairment or distress. This diagnosis is based on a pattern of cannabis use leading to clinically significant criteria like a persistent desire or unsuccessful efforts to cut down or control cannabis use, spending a great deal of time obtaining, using, or recovering from effects of cannabis, craving, failure to fulfill obligations at work, school, or home, continued use despite problems. And we know that about 1 in 9 cannabis users develop CUD, but this hasn't been studied in a medical population. We didn't know if those using medically were somehow protected from developing CUD since their motive was health related. But it turns out that they were not. So this is participants' percentage with CUD. This is our delayed acquisition group, the waitlist group, and we see it's about 5%. So some people will develop cannabis use disorder naturally. But in our group that got the card, what we saw is that there was this rapid escalation of cannabis use disorder, particularly in the group using cannabis for depression and anxiety. It was almost 20% by the 3-month time point of the trial. So there is a potential downside of using cannabis for medical conditions. Cannabis use disorder increased by 3 times in the medical marijuana card group. But did it help their symptoms? What's a little CUD if you're experiencing, all these medical benefits? So unfortunately, we didn't see medical benefits. So this is an effect size. 0 means nothing's going on. So let me go through our outcomes. These are CUD symptoms. So this is worsening CUD symptoms when they had a card. Pain severity, nothing. Depression, nothing. Anxiety, nothing. So no effects in depression and anxiety. We did see a nice bump in sleep. Excuse me. So people did report sleeping better in the first 12 weeks of the trial. And I think that was because cannabis was helping people fall asleep. We don't know if that would persist after the first 12 weeks of the trial. At each visit, participants provided a urine sample and they reported whether their products were THC dominant, CBD dominant, which is cannabidiol, which is supposedly a medicinal compound in cannabis, or had approximately equal CBD and THC. And we tested for all different metabolites in urine. What we found when we looked at the urine was a lot of people weren't getting the products that they expected. Among participants who reported using CBD dominant products, there was no CBD metabolites in 30% of samples. Among people who were using equal or THC dominant or equal CBD THC products, there were no THC metabolites in 35% of samples. Vaping was the most common method of administration, but 20% of samples contain no measurable cannabinoid whatsoever. So what are people buying? Maybe they weren't using enough, but what I think this means is that this is very poorly regulated, and a lot of these products were not what people thought they were. And this is important. I'm just going to read a quote from a participant. This was a real life participant. I was taking what I thought was CBD oil, and apparently it wasn't what I thought it was. I started feeling the effects when I was driving, which was really scary. I got home as quickly as I could. I felt so high, I didn't know where I was and couldn't focus. And the only way I got home was the noises from GPS. I was paranoid that I might have hit someone or something, but I checked my car and there was no damage. So here, this is a woman. She thought she was taking CBD oil, which is not supposed to have THC in it. Apparently it did. She took it before driving, and this was her experience, which was quite scary for her. So what can we say from this trial? So this study suggests that healthcare providers and patients should be cautious about using cannabis, especially for people with mood disorders who might be at higher risk for developing cannabis use disorder. Although many states allow medical cannabis for various health issues, there's limited proof of its effectiveness. More research is needed to better understand risks and benefits for specific medical conditions and to see how risks of developing CUD changes with longer use, particularly in those with mental health conditions. And this information will help doctors and patients make better decisions about using cannabis for specific health problems. I've shared a lot with you today, but I'm going to return to my punchline, which is that cannabis really is failing to deliver a lot of the benefits that people have been hoping for. And here are some thoughts about, where I think we need to go from here. I think we need more research on the effects of cannabis on the brain. We need to know about different cannabis products, vapes, waxes, high THC varieties, different subpopulations with psychiatric comorbidity, with other substance use. If there are medicinal benefits to cannabis, and I believe there may be, and I'm actually quite interested in medicinal benefits, and I'm studying those in my lab, but we need to study them as a medicine in defined doses with known concentration for specific medical condition. Researchers and policy experts really need to join forces to get this accurate, unbiased public health messages to the public about risks of cannabis, particularly to adolescents and young adults. So with that, I'm going to stop and take questions. And I have to thank my lab who helped me with all this research and my funding sources who funded the study. And thank you again for inviting me today.
Thank you so much for the great presentation, Dr. Gilman. It was very informative with a lot of great information. We do have a couple of questions in the chat and Q&A. As a reminder, we ask that all questions be submitted through the Q&A function, and that can be found at the bottom of your screen. Also, as a reminder, this webinar recording and the presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. So let's get into some questions. Kathy asks, do the majority of dispensaries have cannabis with over 10% THC?
Yes, that's easy. Yes. Yeah. So commercialization. So this is a complicated issue. So a lot of people, particularly progressive people who don't like, the thought of throwing people in jail for using cannabis, and I'm one of them, are supportive of decriminalization, and I am as well. No one, I'm an addiction researcher. I think people need treatment, not jail. But commercialization is really another step. So there's decriminalization and then there's commercialization. Commercialization is letting market forces take over, letting market forces do what they do, which is to sell products to people. And this is not like selling toaster ovens or selling, selling normal products. This is selling an addictive substance. So market forces will make more money by addicting people. We have learned this lesson. We have learned this lesson from tobacco. We have learned this lesson from alcohol. It is to their advantage to create highly potent products. So the marketplace, I think, really fails us here. And yes, most marketplace cannabis is quite high in THC, and that's because there's a vested financial interest in making it that way.
Thank you. And that kind of leads into a question in the chat. Is information like this made available to state and federal politicians?
I mean, I hope so. I think as scientists, translation is always a little hard because we publish in academic journals that aren't read by politicians, but I hope by, these sorts of venues, these messages can get out there. I think it's really hard because there's a lot of political will. Again, and again, I really have a lot of empathy and sympathy for not wanting cannabis to be criminalized, and I share that. I just think that the commercialization is problematic in a lot of ways. So I hope that policymakers are aware of this, and I'm happy to talk to anyone with connections to help make that happen.
Thank you. We have another policy-related question from Hannah, who asks, with the Supreme Court overturning Chevron, what does it mean for cannabis production? If it already wasn't FDA approved, will this impact youth and adults who use cannabis? And are there any things to be aware of or look out for community members, patients, clients?
That is such an excellent question that I am completely unqualified to answer. I mean, this is, hot off the press. I think we have no idea what overturning that decision will mean for federal agencies, for the FDA. I think it remains to be seen. I'm not a lawyer, so I don't want to say anything inaccurate that doesn't speak to my own expertise in science and the effects of cannabis on the brain, but it does worry me. And I think as we, are in this era of deregulation, this might work well for certain things. It does not work well for addictive substances for the reasons that I stated, in the past response, that highly addictive substances will make a lot more money when they addict people. So I do worry, and I share your concern, and I don't know what the fallout will be.
Absolutely, thank you. And then related to the money-making industry, so Kathy asked if we can expect any public service messages directed toward adolescents with it being such a money-making industry. Is that something we can look out for, do you think?
Yeah, and I think there's so when I started this research 10 years ago, people didn't want to hear it. I got a lot of pushback. People would yell at me when I gave these talks. They'd be like, "Oh, you're overstating this. It's not heroin, it's just cannabis." And that is totally true. This is not heroin. I'm not equating it with heroin. People are dying from opioids. People are not dying from cannabis. It's not the same. But that doesn't mean it's harmless, and it doesn't mean we should be encouraging use. And people will say, well, isn't it better than alcohol? Wouldn't you rather your kids use cannabis instead of alcohol? And I just think that's a false dichotomy. How about we discourage both? Because we know that people use both together. It's not like they stop using one when they use another. Substitution has not panned out the way some researchers thought it might. And we know that kids who use cannabis use nicotine, use alcohol, and are more likely to use illicit drugs. So I don't think we should be encouraging use in any way. I don't think we should see it as the healthier alternative. Kids are going to do what kids are going to do. We don't have to scare them. We don't have to overstate our messages, treat them like intelligent people that they are. and show them this data. Show them it's going to affect your learning. It's going to affect how you perform on tests. This is an important part of your life. You're going to be applying to college, or you're in college, your grades matter. This isn't good for you. I think that's a message that should get out. And I think we're getting better about that. And the message is starting to resonate. I actually see a question in the chat that I really do want to answer, if you don't mind. And this is from Christina, asking about recommendations for impairment measures for cannabis, given that we don't have the equivalent of a BAC. This is something that I care deeply about. And part of my research is looking at other metrics of impairment that can be assessed at the roadside. That's such an important point. We don't have a cannabis breathalyzer. Even if we did, it wouldn't work. Because so alcohol has a very nice correlation with crash risk. The more alcohol you take, the higher your crash risk. And we've determined that 0.08 BAC is the legal limit in this country. We don't have a legal limit for cannabis. And what we find is that the amount of cannabis in the breath doesn't correlate with impairment particularly well, because of things like tolerance and pharmacodynamics and pharmacokinetics. And I can talk all about the biochemistry if you want. So what we're working on developing is some sort of brain-based metric for impairment. But I think that this is going to be challenging. I like to say that the policy is ahead of the science here. We've legalized cannabis without understanding how to assess impairment in a driving situation. And I think new methods are going to be needed that really assess behavioral metrics of impairment rather than just a biological, THC level in the breath.
Yes, thank you. We do have a question about cannabis showing up in urine as well. So this person asks, the urine samples that showed a lack of difference in the potency of cannabis levels was concerning. What is showing up in the urine samples from products bought at dispensaries?
Those were products bought at dispensaries in the study, and I totally agree. There have been some studies where people have bought products and tested them for their constituents, and they're really off. They're really off, and that's because there's poor regulation. So there have been a few studies where researchers have bought products online and tested them, where they've bought products in dispensaries and tested them. And what we did, we weren't allowed to test the products because of federal regulations, but we tested the urine of our patients. And we found out that, what was in their urine was different than what they were reporting. And I think the only thing to do about that, to improve that situation, is to have better regulation. That wouldn't happen in a pharmaceutical drug. That would not happen in, Advil or Tylenol or any of the drugs bought in pharmacies or at drugstores, because there's really tight regulations about what can be in these drugs, and you have to have product labels that are precise. For cannabis, nobody's checking. It's sort of the Wild West out there.
Absolutely. That is very concerning.
Yeah.
Right, let's see. We do have quite a few questions. We have about 5 minutes left, so I'm not sure we'll get to all of them. But we do have a question about the study where kids were given money to stop using cannabis.
Yeah.
And someone does ask, what is a good amount to entice them to quit? How much were they paid?
Well, you're gonna laugh. They're actually paid $420. People laugh because 420 has some sort of significance in the cannabis arena. But yeah, so we paid them escalating payments over the 4 weeks, and the payments started out small and got progressively larger. And that way they're incentivized to maintain abstinence over time. And they got a bonus payment at the end. And they were quite successful. And this is called contingency management. What we found is that this is a viable treatment for a lot of addictive substances. You have to incentivize people. The problem is they don't immediately start feeling better. They actually feel worse. When people stop, whatever drug it is, cannabis, alcohol, opioids, when people stop using, they feel pretty terrible. They have withdrawal symptoms. They feel irritable. They're tired. They're lethargic. Other drugs of abuse, opioids, alcohol have some terrible withdrawal symptoms. So they sort of need that extrinsic motivation because intrinsically is not motivating to stop using a drug initially. It is in the long term. And at the end of the study, a lot of them said they felt better. And they said, maybe I'll use cannabis again, but I want to reduce. Or, this is working well for me and I feel better and I'm going to try to not use. A lot of them go back to using because their friends use and that's part of their social circle.
Right.
But I think the payments really did help keep them motivated.
Great, thank you. We also had a question about that study, which I believe was from 2018.
Yeah.
And someone was just asking if there's been any follow-up studies on that, confirming the findings since 2018.
Yeah, actually, we are working on another paper following up on that finding, looking at younger kids and looking at more variation in cognitive tasks. So I don't have data on that just yet, but stay tuned. And that should be published, I hope, in the next 6 months or so. It's a good question.
Thank you. Let's see. We do have a question about, is there a placebo effect with cannabis? So if products aren't containing cannabis, but people are using those products, is there some sort of placebo effect?
That's an excellent question. We were quite worried about a placebo effect in this trial. There was no placebo. It was you either use or you don't use, and we'll compare. And we thought, these people are believers. They really want it to work. Are they going to say it's working, even if it's really not? And we didn't see effects even despite the emergence of a potential placebo effect. So I was pretty confident that cannabis was not effective for pain, anxiety, or depression, because you would even expect a small bump for placebo, and we didn't even see that. And a lot of people were quite disappointed. We conducted this trial starting in 2018, which was when medical dispensaries started opening in Massachusetts. Well, the law was passed in 2016, but it can take some time to get implemented. And people were excited about it. And people were like, I've been wanting to try this. I've been wanting to try this for my shoulder injury. I've been wanting to try this for my anxiety. And a lot of them were quite disappointed at the end of the trial. And they said, it didn't, maybe in the moment it helped a little bit, but it certainly wasn't as effective as I had hoped. So and the sleep bump was interesting. I think that a lot of people used it right before bed, and then it would help them, relax and fall asleep. But when we looked at sleep scores, when we looked at actual insomnia scores, it was a very small bump. So they said it helped them fall asleep, but they still had the underlying insomnia.
Thank you so much. We do have a question about cyclical vomiting disorder, and if there's been any research on that in adolescents.
Yeah, I haven't researched that personally, but it's something that I have read a lot about, and I think it is so underreported and it's even doctors don't know about this. So I've had people say I have to go to 4 doctors before anyone suggested that cannabis was causing this cyclical vomiting. And basically, for people in the audience who don't know about this cannabis hyperemesis, some people, they think it's almost like an allergy to cannabis. Some people who use cannabis end up with this cyclical vomiting syndrome where they just can't stop vomiting. They get super nauseous. A lot of them have to take super long showers. And the treatment is just to stop using cannabis, and it goes away. And it's really easy, and people think there's something terribly wrong with them. And people go from doctor to doctor to figure out what's wrong with them, when a lot of doctors don't even know about this cannabis-induced hyperemesis. So I think it's incredibly interesting and disturbing, and I wish more people knew about its existence.
Yeah, that is very interesting. Thank you. So I think that maybe we'll answer one more question because we are at time, and then just wrap up for today. So there is a question whether you have any educational programs that schools can use, any you recommend or know
I
of?
do. Yes, I do. So my lab has developed something called I Decide. If you give me a second, I'll put it in the chat.
Great.
And that's exactly what it is. This is basically a drug use curriculum for schools. And in Massachusetts, we've enrolled over 400 schools into this. Here, I don't know if everybody can see this link, or just the hosts and panelists.
I can post it to everybody.
Perfect.
So
Yeah.
there.
Yeah, definitely check it out. And if you're interested, contact us because this is something that we care very deeply about.
Great. Thank you so much for sharing that information and all of the information that you've shared with us today. And thank you everybody for attending. We hope that you found the webinar informative and interesting. We would greatly appreciate your feedback so we can continue to improve our webinars in the future. We have a link just went in the chat with a survey, and we'd greatly appreciate if you complete that survey. As a reminder, this live webinar has been approved for 1 social work, 1 McBAP credit hour, and 1 CME credit hour. So if you are requesting any of those continuing education credits, please fill out the evaluation form and just put in the fields that you are requesting that certain credit. Put your name and address in, or email address in the survey, and then we can get that certificates out to you. For our next presentation in our series, Dr. Ken Finn will be presenting on cannabis, opioids, and public health implications. That will be tomorrow at 12 o'clock Eastern Time. Dr. Finn's live presentation has also been approved for 1 social work, 1 specific McBAP credit hour, and 1 credit hour of CME. And if you have not yet registered for the other webinars in our series, you can do so by using the link in the chat or visiting our website at washtenaw.org/marijuana. We hope to see you there, and thank you for your participation.
Thank you so much. Thank you for all the great questions.
Thank you, Dr. Gilman, for presenting.